This program is brought to you by Emory University.
Well, I guess we'll go ahead and get started. Thank you, everybody, for joining us in person or on Zoom. We are in the Hearst Conference Room, so if you're around the hospital, feel free to mosey on down the hall. It's my pleasure today to introduce Ravi Karra, an associate professor from Duke. Ravi's a native of Wisconsin, but he actually did his medical school down at Duke and then went on to internal medicine at Brigham and Women's. After which he returned to Duke, did his cardiology fellowship, heart failure training, and research training, and stayed on there as faculty. Now, as part of his training at Duke, he actually worked in Ken Poss's lab studying mechanisms of heart regeneration. So like me, he's one of the very few heart failure trained cardiologists who also runs a basic science lab. And actually, for those who are interested and can possibly attend, he's going to talk about his more basic research work at the 9 o'clock CV Bio meeting. The Zoom link for that's in Santa's weekly email for anybody that's willing and able. Now, clinically, his hat within heart failure is infiltrative diseases. He runs their amyloid and sarcoid program. And today he's going to be talking to us about cardiac sarcoidosis. And I would say, well, at least I'm guessing, that he's one of the very few people that actually has real research money to study cardiac sarcoidosis. Very understudied disease. So very interested to hear what updates he has for us in sarcoidosis. So I'll turn it over. Thanks.
Thanks, Mike. Thanks for inviting me, and it's great to be here. I actually haven't been to Emory, and just a wonderful campus. It's just gorgeous. So great place to be. So today I'm going to talk to you a little bit about a program that we started a couple of years ago at Duke, really around precision cardiomyopathies, and specifically I've been leading the sarcoid program there for the last couple of years, and just tell you some things that we've our way of doing things, kind of review sarcoidosis for those on the call, just sort of an education thing, and then talk a little bit about some of the research that we've been doing in this space. So just to get this out of the way, no disclosures, sadly. So as a heart failure doctor, we all have this same problem, is what do we treat? Should we be treating everybody and really investing resources into implementation science and really getting people onto the best medicines possible? Or should we really be parsing the population into a smaller subset and really focusing on these targeted diseases and defining them in a sort of way? And so at Duke, we tend to have this push-pull, as I'm sure everybody does. Do you invest in these large medication titration clinics, these population-based screening programs, or should you really thinking about drilling down and establish subspecialty care? And in my opinion, this is actually not really much of a dilemma. And so if you go back and think of the latest, greatest clinical trials, and this is a slide courtesy of my colleague, Rob Mentz, even if you look at modern medical therapy, where you've got quadruple therapy for heart failure, here looking at Emperor reduced, if you look at the area under the curve in the empagliflozin arm, there's still a lot of territory to touch. If you look at the rate of cardiovascular death or hospitalization, it's still pretty substantial. And so this has been an outstanding question in heart failure. And one of the ways that we're interested in talking about it is to really get into precision. And the reason for that is actually very old. I keep reminding Mike Felker, who's also one of my partners, that this was done a quarter of a century ago. He doesn't like use of century in that phrase. But this was done a quarter of a century ago, where he did this really meticulous chart review. He did it with Dr. Boffman, and they looked at biopsies and chart review, and then looked at outcomes. And so back a quarter of a century ago, very clear that the type of cardiomyopathy you have, the cause actually matters. And in this era, peripartum cardiomyopathy did the best. And interestingly, HIV cardiomyopathy did the worst, something that we often don't see anymore as treatments have changed. And now you fast forward, again, a quarter of a century later, and you look at this era that we're in, and it's very clear that not only does cause matter for prognosis, but if you treat the cause, that actually matters quite a bit. And so just as a great example, on the far left here, far two left articles that I show here, for acoramidis and tafamidis, very clearly we've pushed the needle in amyloidosis. Again, when I was training about 10 years ago, I didn't want to know if anybody had amyloid because I had nothing to do for it. But now seems like we're searching for everybody, and we're actually turning things and figuring out that there are false positives of amyloid diagnoses. And then similarly, if you look at hypertrophic cardiomyopathy, as it can drug the sarcomere now, that landscape's changed too. So the bottom line is cost-specific treatments improve outcomes. And so looking forward and kind of getting at this goal, one of the things that we've been interested in this very busy slide, and this is, I think, reflects sort of the complexity of modern heart failure care, is to think about how can we address this need? How do we balance that need of population-based care where we need to get people on GDMT versus subspecialty and specialized care? And so we've really broken our heart failure program into a couple different buckets. The first is our general heart failure bucket, and so that facilitates the population-based need for our patients. So things like a heart failure medication titration clinic, a same-day access clinic, which is effectively a heart failure urgent care, a PharmD clinics, and then even this undifferentiated shortness of breath clinic. And then on the other side of the spectrum, which many of our colleagues across the country know Duke for, is that we have a very, very bustling advanced heart failure program. And we do a lot of LVADs, we do a lot of transplants. But we've figured out that there's this space in between, that is fully possible, that you can actually provide all these other services. And in fact, they're complementary to a precision program. And so we focused on a few key areas that we've highlighted for strategic growth. And the last couple of years have really focused primarily on amyloidosis and sarcoidosis, largely because the therapeutic landscape has been defined. And then other areas that are a bit more investigational are coming on. But our overall strategy is that when we created a cardiomyopathy center, or are creating a cardiomyopathy center, is to really create these domains where we could both bring new therapies and serve patients well, but also push the science additionally. And so this has been something that has been a project that's been going on for about two and a half years. So today I'm going to tell you about the part that I've been primarily leading, which is sarcoidosis. And there are two real major goals to my talk. The first is just to simply provide an overview of the disease, just to remind you, it's probably not something that everybody thinks about every day. And then talk about what our general approach is at Duke. And then the second one is just talk about some of the places where we think that discovery and some of the things that I like to do in the laboratory might help and push the needle on this disease. I realize that it's early in the morning, and probably many of you, especially on the Zoom call, are probably getting kids to school. So if you hear nothing else, here is the one slide to take away. It's the too long, didn't read version of this entire talk. So just to remember, sarcoid is an inflammatory cardiomyopathy. It usually occurs with other organs. It typically manifests with arrhythmias, both the fasts and the slows. So slows typically heart block, and fasts with most, in the worst case, ventricular arrhythmia, and then often occurs with heart failure, but is primarily arrhythmic and arrhythmogenic cardiomyopathy. It's treatable with immunosuppression, except what that immunosuppression is poorly defined. So it's dealer's choice on what you want to use. And then the problem with it is that there are bad diagnostics. And so oftentimes we're left guessing at the diagnosis. So if anything you take away, this is the one slide to take away. So getting into some of the details, as a refresher, cardiac sarcoidosis is actually not all that common. As you know, sarcoidosis itself is a pretty common disease, and about 25 to 50%, depending on the series and the geography of where those cohorts have been assayed, 25 to 55% of patients with systemic sarcoidosis are going to have some evidence of heart involvement. But very interestingly, not all of those patients get sick. Oftentimes, cardiac sarcoidosis is asymptomatic, and it's only about 5% of patients that, compared to autopsy series, that have cardiac involvement that result in disease. However, when it happens, it's bad. And when it happens, it's actually a major cause of death in these patients, up to a quarter of all deaths in sarcoidosis. And this last entity is probably the part that takes up the majority of my practice, which is that and sometimes cardiac sarcoidosis doesn't affect other organs, and sometimes it's just simply isolated to heart. And that's up to 25% of cases of all cardiac sarcoidosis according to autopsy series. And this is completely maddening because you can't find other places to biopsy. And as we'll talk about later, it's not like you can biopsy the heart very easily either. As a reminder, cardiac sarcoidosis is primarily an arrhythmogenic cardiomyopathy. And so this is a series taken from Finland where they looked at consecutive cases of patients with cardiac sarcoidosis and how they presented. And so as you can tell from the Venn diagram, the majority of this is going to be arrhythmias. So a big chunk of people show up primarily with AV block. And again, that tends to show up and relate to where the anatomy correlates with the disease. And then a smaller number of people are going to show up with VT and sudden death. And actually, not that many people will show up with heart failure. So again, even though as an advanced heart failure physician, I tend to see a lot of the low output individuals. This is primarily an arrhythmic disease. And so that's had some implications for us as we plan our clinic. We are very, very closely aligned and had to get a lot of buy-in from our EPs to get this program up and running. As I alluded to, how sarcoidosis presents is typically a manifestation of where the disease is. So this is a diagram taken from really last year's guidelines by American Heart, published in Circ, looking at how to manage and diagnose cardiac sarcoidosis. And I thought this figure was really nice, and this breakdown was nice. Is that cardiac sarcoidosis will typically involve the infrabasal septum. And if that's the only place where it's going to show up, the typical dominant manifestation will be heart block. Makes sense. That's where the wires live. But if you have delayed enhancement, that tends to involve patchy involvement in the ventricle, and that's when you tend to get other manifestations of the disease. So not only heart block, but you can get ventricular arrhythmias and ventricular dysfunction. In fact, when we look at our own data, and it's something I'll show you a little bit later, the more extensive the involvement in the heart, that directly relates to the risk for heart failure. And then there can be these atypical patterns. And with that they tend to be a little bit more ill-defined. And so I will say that in our experience, when we look at these atypical patterns, although in certain cases we really need to say that it's cardiac sarcoidosis, oftentimes that's the place where you have to be really skeptical about the diagnosis. How do you diagnose this? Well, there are various criteria, and these are really great for your medical students. Honestly, I can't remember any of them. And it's always challenging whenever you have these criteria, they're like too major, too minor, things like that for me. And these criteria are imperfect. And so to remind you, there are really two commonly used criteria for diagnosing cardiac sarcoidosis. On the left is the HRS, the Heart Rhythm Society criteria, and on the right is the Japanese Ministry of Health criteria. They tend to be pretty similar. So if you've got tissue biopsy somewhere else and you've got a compatible clinical syndrome in the heart, you probably have cardiac sarcoidosis. However, there is this clinical pathway, and that's really was designed to acknowledge the fact that there's a large amount of cardiac sarcoidosis that simply involves the heart and nowhere else, where tissue diagnosis is just simply not possible. However, these were designed to be sensitive and not particularly specific. And so I'm going to just name out two. So if you look here, it says 2 of the major 5 criteria. Again, as an advanced heart failure doctor, I'm going to name out 2 criteria for you. And if we follow this, every one of my patients would have cardiac sarcoidosis. So everyone with, if you have LV dysfunction, so again, that fits. And then any gadolinium enhancement of the heart. I mean, that's all my patients. So not everyone has cardiac sarcoidosis. So that doesn't fit. But again, these criteria were really designed to increase the sensitivity, but not necessarily specificity. And so that's been a big hole in this field right now. So again, I mentioned I can't remember these things. So we've kind of broken it down into a way that a simpleton like me can actually work through this. And so this is kind of our approach of making a diagnosis. The first step is thinking about it. And so in someone that has a compatible clinical syndrome, again, the slows, having AV block and having ventricular arrhythmias that might be unexplained or undefined heart failure, first is to get some imaging. And so we take a picture and we say, does the pattern look like cardiac sarcoidosis? And then our next question is with imaging is to determine whether or not it's active, a disease, or simply burned out. So to remind you, kind of like what we showed you earlier with that circulation guideline, we kind of know where sarcoidosis tends to affect the heart based on these beautiful autopsy series that have been done. And almost always it's going to in fact impact the infrabasal septum, and it will have septal involvement. There are very few things that are going to involve the right ventricular side of the septum. We'll talk about a few of those mimics later, but by and large, this is where it's going to live, and so that's really important. Where in the heart is it impacted? Of course, autopsies are bad things for patients, and so we use our surrogate test for that, and that's cardiac MRI. In our practice, cardiac MRI is a major modality for evaluating cardiac sarcoidosis, and so this is some work led by Dr. Manesh Patel, who's our division chief, back when he was a fellow with Ray Kim, who really has done a lot of work to establish delayed enhancement to show that it is the imaging correlate of scar pattern. And so in this study that they did really now more than a decade ago, they took 15 patients with pathologic sarcoidosis and then looked for whether or not they had heart involvement. And again, it's kind of, in these days, I feel like the bar for publishing can be quite high, but only 15 patients, and they did a well-designed study. And that what they showed is that if you had delayed enhancement of the septum, that would highly correlated with the probability of having biopsy positive cardiac sarcoidosis. So we use this as a guide to say, where is the scar pattern? And so sort of answer the question, do you have cardiac sarcoidosis or not? Since then, the research has moved quite a bit. And so in this work by Chetan Shenoy, who was a fellow with us and then now is faculty at the University of Minnesota, he took this and said now that we have, when they looked at, I think it was about 500 cases for them, and they looked at delayed enhancement patterns on cardiac MRI and what that looked for in terms of prognosis. And the upshot of this is that these are separated by arrhythmic outcomes on the left and heart failure outcomes on the right. And it's a little bit hard, but there's one line that sticks out the most. That's right here. And it's the SAGE line. And basically that is a group that has a delayed enhancement pattern that's typical for cardiac sarcoidosis. That is the group that's going to have basal, infrabasal septal involvement and septal involvement. So that tells us a couple of things. One is that's the group that's going to have these things that we associate with sarcoidosis. But more importantly, it tells us that if you're in patients with sarcoidosis, if they have normal hearts, the normal ventricular function and no delayed enhancement, their chance of having clinically meaningful cardiac sarcoidosis over the next 10 years is actually pretty low. So for us, that negative predictive value is actually really, really important. We get asked by our colleagues in the sarco community a lot, is the heart involved? So for us, if we get an MRI and it's completely negative and the heart's normal, we can say, thank you. We think the chances of you having something bad happen because of cardiac sarcoidosis is pretty low. And so the MRI itself is a really, really good test to ask the question, do you have sarcoid or not? Of course, the second modality that we use quite a bit is going to be FDG PET imaging. So here's some kind of idealized images. So typically in these studies, one will get perfusion imaging and FDG imaging at the same time. And so here they're using ammonia imaging to look for perfusion and then FDG. And typically where you see inflammation, where there is a perfusion defect, that tends to be the most specific for a sarcoidosis, and there aren't that many things that do that. So that's a good marker, and so we try to match those up quite a bit in our practice. And of course, the nice part about FDG PET imaging is that unlike scar, which doesn't go away, you have something that you think can go away with treatment. And so here in this example, here's an individual that got treated with steroids for some time, and you can see that before treatment. On the left, you can see the heart lights up relative to the blood pool. There's a lot of inflammation, but then when you look after treatment, now you see myocardial signal that's far less than the blood pool, so that the inflammation has resolved. And so, and interestingly, the perfusion defect seems to have gotten better too. And so this is a great test to look for things to treat, and oftentimes we'll use this as our way to follow the disease. So I kind of alluded to this earlier, and I'm sort of setting this up. And the idea is that while our imaging modalities are pretty good and they can give us increase the likelihood, they're not specific. And in fact, in this era where we can better test for hereditary myopathies, one of the accidents of our sarcoid program was that a lot of people we were getting just had really positive imaging, but didn't have sarcoidosis. And when we did genetic testing, we started to see a lot of hereditary variants. And so really, as an offshoot of this, we created a hereditary, or actually are creating a hereditary myopathy program. And this is an experience that we've had that others have recently described as well. And so just to give you the types of variants that we typically see as sort of mimickers of sarcoidosis are going to be the lamin A variants, filamin C, the desmoplakins, and other ARVC type of variants. So it's very, very common to see positive PET scans in those entities. Interestingly, we don't always see the matching perfusion defect, and so that's going to be an interesting area to figure out if that actually is something that can differentiate the two entities. Well, certainly the problem is trying to make this diagnosis and being specific with it. And so one way to do that is to get a tissue diagnosis. And as a part of our sarcoid program, we made lots of friends, and we want to really grab tissue wherever we can. And so, I feel like I think as I get older as being an attending, I start to say the same things that my older attendings used to say. So it starts with a physical exam, and it's just so true for cardiac sarcoidosis. If we do, you have to do a good skin exam, and that's the easiest place to get a biopsy from. And we luckily have been able to partner very closely with our dermatology program, and we have an immunoderm program. So I don't know what it is like here, but in Durham, North Carolina, to get a dermatology appointment is like a year. It's like easier to get the best Jordans than it is to get like a dermatology appointment. So having a immunodermatologist on our group has been really vital. We can call them and get rapid access to getting a tissue diagnosis, which is great because that means we're not delaying treatment if we need it. The other place that we're biopsying a lot, of course, is going to be the bronchial lymph nodes. And so having a pulmonary group, which has traditionally been where a lot of sarcoidosis care has been had, have them dialed into your program is really important. So we really try to do whatever we can to make a tissue diagnosis. There's nothing worse than going to an isolated cardiac sarcoidosis. Things aren't getting better, and you're putting people on massive immunosuppression and saying, I actually don't know if you have the disease or not. And so we really, really want to avoid that as much as possible. So trying to find extra cardiac tissue is really important. Sometimes you just can't find it, and that's where you have to do endomyocardial biopsy. We really try to avoid this as much as we can. And the reason is that endomyocardial biopsy, because of the patchy nature of disease, is really only about 25% sensitive. So just putting that from the patient perspective, that means that if you find it, it means you got it. But if you don't find it on biopsy and you went through the risk of doing that, it didn't tell you anything. And so we really try to avoid this as much as possible. We've done iterations of this that have been talked about in the literature, for example, voltage-guided mapping. So sometimes our EPs will do this, a voltage-guided biopsy for us at the time of ICD implantation. But even that's only increases it to about 50% sensitivity, and we typically don't. I will say that my colleagues in the cath lab hate this slide because this is obviously coming from the neck, and they don't do that. They typically will go from still do femoral based biopsies. But the reason for making that distinction is that based on the approach, there probably is a little bit of bias of what part of the RV septum you're getting. So how do we put all this together? This is kind of another one of those TLDR slides. So in the right clinical context, so again, having a patient with the right clinical presentation, the way we look at it is if you've got compatible clinical imaging, it's possible you have it. If you have imaging and some tissue from not the heart, it's probable that you have it. And then if there's imaging and cardiac tissue that says you have sarcoidosis with granuloma, definitely have it. So the next part is getting into treatment. So the first question is, why do we care for sarcoidosis? And so this is data taken from a Dutch registry, 12,000 patients over a long period of time. and compared to their population controls and looked at cardiac events. And so in the red line, that's the sarcoidosis population, and the blue line is the background population. And what you can see is that the red line has higher events of heart failure. They have higher events of, in this case, atrial fibrillation and all-cause cardiac mortality. So again, going back to the point that I brought up earlier, is that when people have sarcoidosis, and there's heart involvement, that's where we think that the risk for these patients really lies. And so we wanted to try to treat. And unfortunately, because of the way that the disease has manifest, most centers have fairly small numbers of individuals with cardiac sarcoidosis. As a result, we don't really have great large trials to say what's the right thing to do. And so this tends to be a lot of the approach to treatment tends to be based on local factors and local comfort. So for example, for us, this is our typical armamentarium. We tend to use prednisone, methotrexate, and anti-TNF biologics. Other centers will typically may sub out the methotrexate as a steroid-sparing agent for things like mycophenolate and azathioprine. But we tend to focus on the top three, but it does seem to be a very center-specific choice in terms of what agents to use. So how do we decide to treat? Our approach is basically if one has sarcoidosis, meaning we're not super confident, but has low risk, and we define risk by VT or having heart failure, we just observe them and just follow them with things like PET scans and MRIs and just say, is the disease chewing up the heart or not? And if it is, then you might treat. If someone has possible sarcoidosis but is high risk, meaning they're sick, and basically they're looking at down the road that they're going to have some sort of advanced heart failure therapy. We say, why not treat them? It's worth the guess. It's worth the educated guess in that point. And so let's see if we can get some response. And so that's something that we do talk to the patient about, describe that there is uncertainty in their diagnosis, but we think that a trial of immunosuppression might be worthwhile. And so that's a sort of what we'd say a measured experiment. And then in cases of probable or definite sarcoidosis, we treat. And the goal there is to try to prevent some of those longer term outcomes with continued untreated disease. Our algorithm for treating this, typically what we do is just a couple principles here. Is first, we start with a fairly substantial dose of prednisone up front and add a steroid sparing reagent. The idea is to use prednisone up front to knock down the inflammation, and then while the methotrexate gets therapeutic. And typically we'll start pretty heavy, and then we tend to, every time we make a therapeutic change, we tend to image at 3 to 6 month intervals. So if we see better inflammation, then we back off therapy. If we see worse inflammation, then we add on another agent. And we kind of do this iteratively. So a couple pieces that have been maybe unique or maybe intuitive to our program is that if we see persistent remission of disease, meaning that we see a regression of inflammation for about a year, that's when we start talking to patients about maybe even coming off therapy. And the rationale for that is that no one knows if continued therapy is a good idea or not in these patients. And so this is a shared decision-making approach. Having had this conversation now really probably half a dozen or probably a dozen times or so, most patients actually elect to stay on some treatment. They're very rare that someone actually wants to come off of everything, and most of it is primarily driven by they want to sleep at night knowing that there's something there protecting them against sarcoidosis. Again, whether or not that really means anything or not is in terms of sarcoidosis prognosis, we don't know, but it does mean something if patients derive some benefit to it. The other nuance here is that sometimes you just don't win. So some people with sarcoidosis can have very refractory inflammation despite using what we call triple therapy with steroid-sparing agents, prednisone, and a biologic. And in that case, those are hard. And so those are the ones that oftentimes we have multidisciplinary groups that meets on a quarterly basis. But of course, we have multiple ad hoc discussions in between. And in those multidisciplinary discussions, we talk about other approaches, sometimes use alternate immunological therapies. But most of the time, those discussions are saying really geared at, does this patient actually have the disease or not? In order to follow disease, we use imaging. Our primary modalities, again, are going to be cardiac MRI and PET. Cardiac MRI for us is a great way to see scar and see if there's more scar happening, so progressive injury that matters. And PET we use for assessing inflammation primarily. You of course can do with cardiac MRI as well, but we find PET to perhaps maybe be a little bit more sensitive. So we tend to do a lot of PET scanning. And then sometimes we'll follow arrhythmia burden on ICD. There are select patients where their disease activity, their sarcoid activity actually corresponds with their PVC burden or ventricular ectopy burden. And so you can look at things like BIV pacing, PVC counters, things like that. And we've had a few people where we've actually quantified or really caught sort of sarcoid flares coming on by their routine ICD maintenance. I put an asterisk here. We put ICDs, but I will say that there are these rare patients that we have in 2025 that actually follow their ectopy with their Fitbit, and it's kind of works. So the morphology changes, and they're very sensitive to it. So where that stands in this will be an interesting place as more and more people have these wearable devices. A question that commonly comes up with sarcoidosis is this risk of sudden death. And so here's the guidelines just for your reference from the CIRC guidelines from last year. Basically, if someone had sudden death, then they get an ICD. Secondary prevention makes sense. If they have low EF despite therapy, they get an ICD. Sort of the same stuff we do for typical heart failure. And then it gets a little bit more hazy. And so if you've got if a patient with cardiac sarcoidosis has an indication for a pacemaker, then they should have defibrillator implanted. They should have ICD at the same time. If they have inducible VT, they should get it. We don't do EP studies on these patients. It's kind of an interesting idea to risk stratify that way, but practically speaking, is not something we typically do. And then there are other things of, basically, if there are marginal cases where you've got scar or sort of an intermediate ejection fraction. And so we use things like non-invasive event monitoring or loop recorders sometimes to try to get at these things. Cardiac MRI is a really good risk stratifier here. So if there's no delayed enhancements, the risk for a heart event is low. So we're not putting defibrillators in people that don't have delayed enhancements. And then even with delayed enhancement, we don't really, looking at it as binary, the positive negative is probably not good enough. You might imagine if someone's got 1% scar, is that positive or is that negative? It's hard to know. And so to try to answer that, one of our fellows, who's now Kelly Arps, who's now faculty at EP faculty at Michigan, she went back and looked at our data set and looked at our registry. And it's projecting a little bit fuzzy here, but basically, if one has double-digit scar, that seems to be the marker where one will actually get will have risk. And so really, once you hit double-digit scar, that's when we get a little bit antsy and start to be thinking more and more towards ICD implantation. Finally, again, I'm an advanced heart failure doctor. So why do we follow these patients' advanced heart failure clinic? And so the end stage of this is treatment really lands in an advanced heart failure space. And so when we think of organ dysfunction, sarcoidosis, we break it into two buckets. One is inflammation, the idea that could be potentially reversible, and the second being scar. So for example, if someone comes in with bad VT, we ask the question, is this due to inflammation? And the primary treatment there would be immunosuppression. Whereas if it's not inflammation, but scar-based, then that's somewhere where our EPs will take the person to the lab and consider VT ablation. In terms of transplantation, we have transplanted quite a few of these patients with this. And so our guardrails for transplantation is if someone's got really bad heart failure, it's not the sarcoid's not active, and they just have the syndrome of bad heart failure. So just like everybody else, then they'd be eligible for transplantation, we'd move forward with that. Other cases, in the case where there is active inflammation, is that if there's inflammation and we're just simply not winning and the person's struggling and they're really debilitated, we just can't find the right immune cocktail to really knock down the inflammation. Those individuals will send to transplant. A lot of times, again, we're skeptical of whether or not that really was sarcoidosis. And so now having done that a couple times, it actually ends up being sarcoidosis a fair amount of time. And then finally, there's the rare case, but it definitely happens where someone presents a very fulminant disease, where they're just in such bad shock that really there's not the weeks to months for the immunosuppression to kick in. And those patients will move to transplant as well. And to remind you, a lot of people worry about transplant outcomes in these individuals. So about every 10 years, UNOS tends to look at their outcomes, and they tend to look at people, look at sarcoid versus not. So here in the red line, so on the y-axis is survival, the red line is sarcoidosis, the blue line is non-sarcoidosis. And what you can see is that the individual with sarcoidosis tend to do better, so or possibly better, but they certainly don't do worse. And this has been a repeated theme over the last couple of decades. So it is a myth that patients with sarcoidosis do worse with transplantation. In fact, if you look at the numbers, it's probably, they actually seem to have less rejection. So that is kind of an interesting goal, but there's not this increased risk of PTLD or anything like that, which many people will worry about. And it's gotten to the point where now some people think that transplant is the definitive treatment for sarcoidosis. That's probably a bit much, but at the same time, there is some truth to this as well. Again, here's our multidisciplinary team. I can't emphasize how important it is to have lots of different specialties involved. There's nothing, these days where it's hard to get into a subspecialty clinic, and access is an issue. There's nothing better than getting up on the phone with somebody and saying, I need you to see this individual. They're pretty sick, and that happening. And so having this core team of, really a sarcoid group has been really great for us, and has really helped move our program in the last couple of years quite a bit. And we've had some good stories. It's basketball season. This is one of our patients who's been very supportive of our program. He's the strength coach for the Duke men's team, and has been a great champion for our patients, has been really great about supporting our program and telling a story, and has really helped a lot of people feel a lot of hope with their disease. And so we've had a lot of support groups where his story and just simply getting his story out through the Duke Press has really been really helpful and motivating for our patients. So in this part, I'm going to take a second to flip switches here and talk a little bit about the research briefly, and just kind of talk about where we think we can innovate in this space. So here's a case that just came to us was someone that was diagnosed as or billed as having cardiac sarcoidosis, 70-year-old man with atrial fibrillation, and here's his MRI, and you see that there's delayed enhancement. That's where the arrows point to, some septal involvement. And then here's his PET scan, and the PET scan shows some patchy inflammation. So the second row and the fourth row are going to tell us that. One may quibble a little bit about the pattern here, but that's, so this person was diagnosed as cardiac sarcoidosis, started on high dose prednisone, and unfortunately had a big duodenal bleed. And so we said, ooh, we don't know if this is what is this, and let's reevaluate. Ultimately underwent biopsy, and the answer turned out to be amyloidosis. And this is not uncommon. Again, there are these mimics of other things. So positive PET scan does not mean sarcoidosis. And so this just really highlights the point that it's just hard to make this diagnosis. We're guessing. These are probabilistic entities. And so for us, we've been really interested in trying to refine diagnostics and improve the precision with what one can do this. And so we've taken two approaches. The first is to repurposing existing diagnostic modalities to apply to sarcoidosis. And I'll show you an example of that in a minute. And then the other one is the discovery of new biomarkers that we can use to better diagnose sarcoidosis. So here's one study. I had a postdoc in my lab, Mohammed El-Ghanani, who's now at ECU. And what his idea was that sarcoidosis is a disease of macrophages. And so if we can image macrophages, maybe that's a way we could improve the diagnosis. And so he first started as proof of concept, where he took a bunch of tissues from our human heart repository and took them from a variety of pathologies: sarcoidosis, healthy hearts, ischemic, non-ischemic, and myocarditis myopathies. and then stain them for macrophage markers. So that's shown here in yellow and in purple. Yellow is canonical CD68, and purple is the CD206, which is more, it's a pan macrophage marker, but a little bit of an M2 bias. And very clearly you can see there's a lot more of the yellow and purple in sarcoidosis than in the other tissues. And if you looked at it across the entire area of the tissue that was sampled, very clearly there's just tends to be enriched in sarcoid samples. So this is kind of a histologic concept that if you could image macrophages, maybe you could get a better diagnostic. And the reason this is relevant is that there's an FDA-approved imaging agent called tilmanocept. And tilmanocept, it basically targets CD206 or the mannose receptor. And so that's the purple that I showed you on the prior slide. And the way this is used currently is that tilmanocept is injected at the site inside of tumors, and the surgeons will use it for lymph node mapping. And so lymph nodes, as you know, have a lot of macrophages in them. And so this does very, very well and is used commonly. And so our idea was whether or not we could repurpose this for cardiac sarcoidosis. And so as a proof of concept, we contacted the company that makes tilmanocept. They gave us an investigational lot where the tilmanocept is hooked up to a fluorescent molecule. And so now we can actually do this. And so this is an image of cardiac sarcoidosis. You can see CD206 here in the third column from the left. You see this patchy infiltrate, so there's a lot of macrophages there. And then you can see the tilmanocept has the same distribution. So we know that tilmanocept does seem to bind this. And so we've now received funding from the Foundation for Sarcoid Research and are testing this clinically to see whether or not this modality can actually be used to identify sarcoid granulomas. The second approach that we're using is to try to find biomarkers. And to do this, one has to go back a little bit in history. There's something called the Kvine test. Probably not many people know about this, but the Kvine test was done kind of the 50s and 60s. Basically, what they did was they took a spleen from someone with sarcoidosis, ground it up, and then they injected it subdermally. And if you inject it subdermally in an individual that has sarcoidosis, a granuloma forms at the site. And if you inject subdermally in someone without sarcoidosis, you don't see a granuloma. So the problem with this is that the cleanliness and of taking someone's spleen, grinding it up and injecting it, that doesn't really fit 2025 standards. We tried, we asked the IRB if they'd let us do it, and they said no, and probably for good reason. But the principle is there. There's really a lot of biology here. That means that individuals with sarcoidosis have an innate susceptibility, and there's some circulating cell that probably, that once it encounters a triggering antigen is going to actually cause it. So this concept has been really interesting to us, and we've been in the search for circulating sarcoid-like cells for some time. And so to do this, what we did was we took 7 of our patients with active cardiac sarcoidosis, isolated their blood cells, and then did what's called single-cell multi-omic sequencing. So that means we took their blood cells and we did profile the RNA of every cell, and then we also profiled their epigenetics with chromatin accessibility. And then we said, you know, can we find a subset that's different in sarcoidosis patients compared to not? And we find all the typical cells that you might expect. But in order to find the sarcoid-like cells, what we had to do was we had to figure out the ones that actually showed up in the granuloma. And so luckily for us, we have friends abroad that had been making these single-cell RNA sequencing atlases of sarcoidosis. And so here there's an immunity paper where they compared affected and unaffected skin, did single-cell profiling. And what they were able to do is find these certain cell populations that were enriched in sarcoid granulomas compared to normal skin. And that's shown here on the panel on the far right. And so what we wanted to know is if any of our circulating cells matched those cells. And so there's a lot of math that goes into this. We have to do a lot of informatics and projections and whatnot. But the ultimate story is that we ended up finding 4 candidate circulating sarcoid-like cells, 2 of which happen to be monocyte macrophages. And when we look at one of them here, this cluster 10, it tends to have all the same pathways that you typically will involve in sarcoidosis. It has activated mTOR signaling, activated TNF-alpha signaling. Again, we use biologics, so that makes a lot of sense, and activated interferon gamma. So we've been chasing this down. And very interestingly, if you look at this cell type a little bit more closely, they actually, these are circulating monocytes express these markers of epithelial transition. And for those interested in granuloma biology, epithelioid cells are kind of one of the really histological hallmarks of sarcoidosis. So if you think about it in tuberculosis, the granuloma's job is to put TB in jail, right? So you create this tight barrier so macrophages express epithelial markers. In sarcoidosis, the same thing happens, but there's not really something that you're putting in jail, but it tends to have these markers. And so finding the epithelioid marker for sarcoidosis has been a problem for a while. But using single cell sequencing, we're able to find alpha-ketinin as our marker. And so here's some confirmatory histological images. So again, we have found this alpha-ketinin positive circulating population, and then predicted that it would light up the granuloma in situ. And so when we do this, so shown here is we have lung sarcoidosis, skin sarcoidosis, and you look at CD68, which marks the macrophages, and then look at alpha-ketinin, which also has a similar profile. So we're now in collaboration with a couple of our colleagues across the country who have registries and blood population, or blood banks of biobanks of patients with sarcoidosis to actually test whether or not we can use alpha-ketinin macrophages as a marker for identifying for sarcoidosis. So with that, just culminate here and hopefully have about some time for questions. Hopefully you take away a couple things. One is that cardiac sarcoidosis is bad, and it requires a high index of suspicion. While it takes a high index of suspicion, usually many times we're wrong. So there's a lot of uncertainty in making the diagnosis. So not only does it take suspicion to make the diagnosis, but it also takes a healthy skepticism to say, do I have the right one in hand? And then finally, this is an area where I think there's an unmet need, but really more broadly, we are interested in this concept that where we can take these unusual cardiomyopathies, find knowledge gaps, and then use discovery to try to see if we can innovate along those lines. So with that, thank really the people who make this work. Our sarcoid group, who I've mentioned in the talk and shown some of their pictures. This group has been really wonderful to work with over the last couple of years. And then my lab, and just really highlight a couple people in particular that have helped move this along. So Kyla was a medical student who's done a lot of our chart reviews and things like that. Mohammed was a postdoc that really inspired the tilmanocept work. And then Anish and Rachel, who are both undergrads and grad students that have been helping with the informatics and confirmation of the single cell data. My lab, as I'm going to talk about it in an hour or in about a half an hour, had nothing to do with immunologic cells until we started doing these projects. And so we had to get good collaborators that knew what they were doing with immunology. And so luckily, David Tobin is down the hall for me, and just a lot of these projects just started by talking at the water cooler and literally. And David is a fantastic granuloma biologist and really helped us push some of these things in new directions. And then collaborating with Adam Morgenthau, who's at Sinai and leads their sarcoid program there, really for helping us with some of these ideas around and discussions around the combined reagent. And then, of course, our various funding bodies that have helped make some of this work possible. And so with that, I'm happy to take questions.
I was quite curious when you said you were, in select patients talking about coming off of therapy. Have you seen recurrences, and how often are you watching for recurrences as you're kind of coming off therapy, and then if they're stable long term?
Yeah, so every time we make a change in medicines, we tend to image about 3 to 6 month interval. It's ideally 3 months, but honestly, we've clogged our PET scanner, and so it ends up being like it's gradually become 4 or 5 months, and so it's not for want, it's more for practicality. That's what it is. I guess we're figuring out what the right interval might be, sort of accidentally. So usually, if we're coming off, we're going to do an imaging study, and then we tend to, if we have one negative study, we tend to push it out another 3 months. So 3 months becomes 6 months, 6 months becomes a year, and so on and so forth. And just to counsel patients, these are the things that you're going to watch out for. So if your device shocks you, that's bad. We need to come in and get a picture. if you're having more heart failure, you've got to come in and get a picture, and that's typically what it looks like. It's really the minority of patients that actually want to come off therapy. There's just something comforting about having your disease treated, and so patients often will say it's not that big of a deal for me to be on methotrexate, and we'll just stay on it. So we've only had maybe 2 or 3 patients that have come off of it, but yeah, I mean, so we haven't seen a ton of relapse that way, but it's small numbers.
So when a relatively young person presents with heart block, we should think about sarcoid.
Yes.
We've had an example of that recently that taught me a lot. That, to my way of thinking, we kind of got off track a little bit, but finally we got back on track with it. But that's part of the differential diagnosis if you have a relatively young person with heart block. Number one. Number two, we've had some personal experience with what I guess we call burned out sarcoid. I mean, it goes into a burned out phase when you end up with a dilated cardiomyopathy. It was one of our cardiac surgeons here who had an ICD and did not go to transplant and had sudden death on the golf course. So it has various phases of disease, and diagnosing it early on is challenging. And I think it's missed a lot, and no telling how many patients with sarcoid out there we don't even know about who present with a lot of ventricular ectopy. And, we have some hesitancy about ordering an MRI because I don't know about Duke, but it doesn't happen in a week. It happens in 2
We have
or
a
3
4-month wait
weeks.
list, 4-month wait list.
So
We got a new MRI scanner too. and
yeah,
it's just
that's hard to deal with, and it kind of turns off our efforts in that direction, which is not exactly appropriate. Maybe it'll get better in the future, but that was a great talk. Thanks so much.
Thank you.
I'll add a plug in there for young patient AV heart block, Lamin cardiomyopathy. Don't forget that as well. Either way, refer him to Kunal.
Absolutely. Lamin is definitely one. Yeah.
I have one, or you could go for the chat.
Sure. Maybe we'll address that. So Rebecca asked, is anything known about the embryonic origin of macrophages involved in sarcoid granulomas? Are these reparative instead of monocyte derived? They appear to, in sarcoidosis, they do. One study that did this was there was an immunological landscape single cell profiling study done by Corey Levine's group that was published in Circulation a couple years ago, and they did a pseudo lineage trace using these pseudo time analyses, and it does seem to be a circulating monocyte that contributes to it rather than resident reparative macrophages. So we think it's circulating monocyte, and I think our data sort of supports that concept as well. The second question is, after 9/11, there was an increase in pulmonary sarcoid. Did cardiac sarcoid also increase? And if not, why not? So great question. It is well known that amongst 9/11 workers that were working in the rubble, that there was a massive uptick in pulmonary sarcoidosis. Whether or not that resulted in cardiac sarcoidosis increase, I don't know offhand. Adam Morgenthau is at Sinai, who's a collaborator of ours, and I believe he did. I think one time we were talking about it, he did mention that's true. But I think the broader question here is about what are the determinants of organ tropism for sarcoidosis? We have no idea, and I think that's an area of active investigation. It probably has to do with whatever the antigen that triggers the sarcoid responses and where the antigen lies. But I think we're not that smart yet to know what that is.
All right, I'll ask a question, and this will be the last because I don't want to get on Xana's bad side. So with the ctNNA, your data here is very compelling. Also comparing though to normals, it looks like. So have you guys looked I'm sure there's plenty of data, single nuke and single cell RNA-seq data in GEO to see if ctNNA is expressed in other macrophage populations, particularly in other inflammatory diseases, i.e. if you go down that pathway, are you going to be
that's a good question. In normal data sets, we don't see it much. It's a very small population. So We're not sure if it's a technique-based issue or what. So, but it just supports the hypothesis that might be a marker. It's probably not a off-on. It's probably the amount of alpha-ketinin that's expressed, and so we just have to do the experiment in a cohort to really know. It's a good point about alternate inflammatory diseases. As you know, GWAS studies of sarcoidosis always land on this small arm of chromosome 6, the HLA region, and that's the same region that's in like all inflammatory diseases, IBD, et cetera, And so there's probably a shared pathology or shared genetic architecture and shared markers. It's probably going to be the same thing. We hope that in the right clinical context, you have maybe that's what works, but really your pretest probability of disease is probably going to be really important in no matter what marker one finds. Yeah.
Looks like maybe there are a couple more from our heart failure folks there.
Oh,
Andy, you want to go first?
Yeah, thanks for adding to my level of uncertainty about life and diagnoses. When you showed the patient that it may have had sarcoid and it turned out to be amyloid, but I do want to ask because I do see where we have patients who have diffuse thickening on their echocardiograms, and someone says, well, this may be an infiltrative cardiomyopathy, and it could possibly be sarcoid. And generally, my thought on that is no, that's not going to be sarcoid where you have diffuse thickening. That's going to be amyloid or some other type of process. But just a comment about that, when the overlap of those are generally not that great.
I mean, it's a good point. That case that I showed is sort of a limit case. Certainly, sarcoid will classically be kind of this heterogeneous hypertrophy rather than this sort of diffuse process as you might imagine. That would, in terms of amyloid in that particular case, is probably an early, at least our guys thought it was an early sort of manifestation, and I think that's where the overlap can happen. I think what adds a little bit of uncertainty to this is that patients don't live in a vacuum. And so it's not uncommon for a lot of patients that we have with sarcoidosis to be quite hypertensive. And so it's not always that we're seeing sort of these lumpy, bumpy, heterogeneous hypertrophy. And so your point's well taken. That's not going to be very common that you would see a overlap syndrome or overlap phenotype of amyloid and sarcoid, but it's just one thing to keep in mind, especially as you're seeing referred patients.
Yeah, hey, Ravi. Thank you so much for a great talk. I'm sorry I'm not there in person today. Certainly, what keeps me at night and is somewhat the bane of my existence is the possible sarcoid patients, as you very nicely showed. One of the most difficult things that I see in our practice here is the ability to adjudicate an FDG PET and try to determine whether this is a false positive or if it's, a positive result indicating another pathology, be it myocarditis, be it a genetic cardiomyopathy. A genetic cardiomyopathy, at least you could do genetic testing for. I was wondering, in your practice, when you've got the possible sarcoid, someone with no extracardiac sarcoid who's coming in for PVCs, and someone got a cardiac MRI that shows some delayed gadolinium enhancement, which then subsequently was followed up with a FDG PET, and now the FDG PET shows, very mild uptake or patchy uptake that doesn't seem to fit the MRI findings, and now you're left with this very uncertain finding. Do you ever invoke things like chronic myocarditis, which is an entity that I'm not still certain I understand? What is your differential at that point? How do you explain it to the patient?
Yeah, it's a great question, and I think the end of the day, it's we're very honest with our patients. Patients are really, really understanding, and sometimes you just tell them, I don't know, and I'm almost never going to know. And so we've had a series of patients that fit that pattern that you're talking about, where we say, look, we're not sure, but how bad like, how bad do you feel? What's your risk? And so if that's where I think patient risk comes into play. And so if you have someone that's having, salvos of VT, if their defibrillator is shocking them, if they're going into heart failure, I think it's worth a round of immunosuppression. If unfortunately, we kind of want to always look at FDG patterns and things like that and say, are we going to get is there some information locked in there that will tell us what this is? And that's not the way that test was made. It's just looking for inflammation in the heart. And that's pretty non-specific. And so I think taking patient risk involved and sometimes it's just giving them a trial of immunosuppression and then seeing if the PET gets better. That's what we've done in those instances.
Yeah, I think the level of uncertainty that exists, especially in the possible sarcoid population, is quite high. And we had a patient just recently that had AL amyloid, but somehow someone ended up ordering an FDG PET for them looking for sarcoid. Thing lit up, and the patient was convinced he has sarcoid, and his light chains were like 1800. So yeah, this FDG PET, they're great for specific reasons, but I agree with you, they tend to be not specific. So I think oftentimes in the community, an FDG PET that's positive is interpreted as active sarcoid, and really it
Yeah. To your point on that,
thoughtful evaluation.
well, one thing is that we tend to repeat a lot of those ourselves compared to the community, just because dietary prep can give you some background too, right? So that's just yeah. So just I think with sarcoidosis, it's great for a scientist because you always have to have healthy skepticism about whether or not you have the right thing or not.
Agreed. Thank you so much.
Sure.
All right, fantastic talk. We'll wrap it up. And anyone that wants to join us at 9 a.m., again, the link's in the weekly email. Thank you.
The preceding program is copyrighted by Emory University.